Ladies and gentlemen, Assalamualaikum Good morning, ladies and gentlemen. Assalamualaikum warahmatullahi wabarakatuh. His Excellency, the head of National Health Biology Laboratory, Dr. Darmawali Handoko, MEP, the Honorable Deputy Director of CDC Country, Mr. Kenchen, the Honorable Dean of Department Parasitology, Faculty of Medicine, University of Kristen Indonesia, also part of Indonesia Society for Human and Animal Mycology Indonesia Clinical Parasitology Association, Dr. Retno Wahyuningsi, the Honorable All US CDC Mycotic Branch, Dr. Sean Lockhart, Dr. Megan Lyman, Dr. Ellison Kavanaugh, Dallas Smith, and Dr. Alexander Jordan, and respectable all participants on this webinar. Welcome to webinar Hidden Hazard Addressing Human Fungal Disease in Indonesia, Thursday, 10 October 2024. I am Janu Arinda, the Master of Ceremony for this event today. On behalf of the organizing committee, we extend our appreciation for your presence today. This event is proudly present by the National Health Biology Laboratory collaboration with US CDC. Ladies and gentlemen, a very good day to all of you. On this occasion, we will hear about the situation of fungal disease in Indonesia and globally, and how we can increase awareness of the threat of disease originating from these fungi. We will also learn to increase competence in diagnosing and managing this disease in Indonesia. We would like to remind those of you who are taking part online to ensure that your internet connection is stable. And please don't forget to complete the pre-test via the link provided. Oke, seminar ini didukung oleh translasi dalam bahasa Indonesia dan bahasa Inggris. Next. Now we move to the first session. It is a welcoming speech by the head of National Health Biology Laboratory, Dr. Darmawali Handoko, MEP. Mr. Darmawali Handoko, the time is yours.
Baik, terima kasih. Tapi ini saya belum video, saya nggak bisa saya buka ya. Oke, sudah. Baik, terima kasih semuanya. Peserta webinar pagi ini harus dipastikan ya bahwa teman-teman yang di Indonesia itu bisa mendengarkan sudah ditranslate. Jadi teman-teman yang belum bisa mendengarkan nanti pada waktu paparan, ada paparan dari luar, itu harusnya bisa terdengar dengan bahasa kita. Ya, baik. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, salam sejahtera bagi kita semua. Om Swastiastu, Namo Buddhaya, salam kebajikan. Akhirnya kita hari ini bisa bersama-sama kumpul di sini. Alhamdulillah. Pertama-tama saya hormati Direktur Jenderal Kesehatan Masyarakat atau yang mewakili. Kemudian Mr. Kenchen, Director of CDC Country Office Indonesia. Terima kasih atas kerjasamanya. Dan dengan para narasumber, Dr. Retno Wahyuningsi, MSSP Parka, ahli jamur Indonesia, dan guru besar FKUI, Sean Lockhart, PhD, Expert CDC, Megan Lyman, MD, Expert CDC, Dr. Alison Kavanaugh, Dallas Smith, Alexander Jordan, Direktur Stakel Kesmas, Izin Kesmas, Kepala Balai Besar Laboratorium Kesehatan Lingkungan, Kepala Labkesmas Tier 4, kita ada 11 regional, Kepala Puskesmas Tier 3, Kepala Puskesmas Tier 2, serta Kepala Puskesmas Tier 1. Serta seluruh peserta webinar hari ini. Marilah kita sama-sama memanjatkan puji dan syukur kehadirat Allah Subhanahu wa Ta'ala Tuhan Yang Maha Esa, karena dalam atas berkat dan rahmatnya kita semua dapat hadir pada pagi hari ini dalam kegiatan pertemuan webinar Hidden Hazard Addressing Human Fungal Disease in Indonesia. Saudara sekalian, merujuk pada Permenkes Labkesmas baik nomor 24 sampai dengan nomor 27 tahun 2023 menyebutkan bahwa Labkesmas merupakan unit pelaksana teknis yang dibentuk sebagai perwujudan penguatan transformasi layanan primer dan transformasi sistem kesehatan Indonesia. Transformasi ini mulai dari tier 1 sampai tier 5. Dan kita tahu salah satunya adalah penyakit-penyakit yang harus kita waspadai. Salah satunya yang mungkin yang ke depannya kita harus juga mewaspadai tentang jamur. Saudara-saudara sekalian, penyakit jamur atau fungal disease menjadi tantangan kesehatan yang semakin meningkat di seluruh dunia, termasuk di Indonesia, meskipun sering diabaikan ya, karena emang jamur itu belum termasuk yang harus kita perhatikan. Padahal jamur itu bisa menyebabkan morbiditas dan mortalitas yang signifikan, terutama pada individu dengan sistem kekebalan yang lemah seperti pasien HIV dan mereka yang terinfeksi penyakit tropis terabaikan. Dengan meningkatnya resistensi antifungal, penting untuk memahami dan menanggapi ancaman ini secara komprehensif. Kita pada pertemuan ini akan menghadirkan para ahli baik dalam negeri, Dr. Retno maupun ahli internasional yang dalam hal ini adalah Expert CDC. Dan acara ini akan memberikan platform untuk diskusi strategis. Jadi teman-teman yang bergabung dalam webinar ini, saya lihat sampai 276 ya, terima kasih. Kita bisa berdiskusi langsung sehingga kita bisa membahas pendekatannya bagi secara diagnosis, epidemiologi, dan pengobatan yang relevan. Dan pastinya saya mengucapkan terima kasih kepada narasumber yang sudah bersedia karena pastinya ada perbedaan waktu ya, hampir 12 jam dari CDC dan kita, dan tapi tetap mereka berkenan untuk memberikan sebagian besar dari ilmunya kepada kita. Demikianlah sambutan dan harapan saya. Semoga kita sebagai jejaring lab dan seluruh tenaga kesehatan mulai menjadi tercerahkan bahwa fungal atau jamur itu juga harus kita perhatikan, bukan hanya penyakit-penyakit yang selama ini ada di kita, tapi kita juga harus mulai berproses penyakit-penyakit yang selama ini kita abaikan. Akhir kata, webinar Hidden Hazard Addressing Human Fungal Diseases in Indonesia secara resmi saya nyatakan dibuka. Wassalamualaikum warahmatullahi wabarakatuh. Om Santi Santi Om, Namo Buddhaya. Dan jangan lupa teman-teman semua, nanti ikuti pretest dan post-test. Dan mudah-mudahan ilmu ini semua bermanfaat untuk kita semua. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Mr. Darmawali Handoko, for the warm welcome. Dear all participants, please remember to take the link of pretest. We can next to the next agenda. Okay. Okay, we proceed to the next agenda. I would like to invite from the US CDC Indonesia Country Office, Dr. Ken Chen as Deputy Country Director of Indonesia Country Office. Mr. Ken, the time is yours.
Thank you. Am I coming over clear? Can you hear me?
Yes, it's clear.
Great. Thank you, Dr. Handoko, and selamat pagi dan selamat datang, everybody. Good morning, all, and thank you for all participants for joining us in today's webinar. My name is Ken Chen, and I'm the Deputy Director for CDC Indonesia Country Office, and I'm representing the CDC Indonesia Country Director today. We are here today to discuss a very important topic in public health prevention, and that is fungal diseases. Fungal diseases might be a rare topic to be discussed, especially in the public health laboratory community. Currently, the testing conducted regarding fungal diseases within the public health laboratory network in Indonesia remains limited. This could lead to a potential health risk. Today's webinar aims to provide insight into fungal diseases that should be considered a priority in Indonesia, as well as to discuss relevant approaches in diagnosis, epidemiology, and treatment. By bringing together local and international experts, we aim to create a productive discussion platform. We believe that collaboration and knowledge sharing are key to developing effective public health policies and programs in Indonesia. I would like to take a moment to extend our heartfelt gratitude to the Ministry of Health, Public Health Management team, and the National Public Health Laboratory team, notably Dr. Handoko, Pak Subankit, Ibu Janu, and the rest of the team for their patience, support, and contribution in making this webinar possible. Your commitment to advancing public health in Indonesia is appreciated, and we are grateful for your effort in addressing these critical health challenges. Thank you, health security partners, in supporting us in today's presentation, Zoom link, and interpretation. I also want to express my appreciation to all the speakers who have generously dedicated their time and expertise to share with us today, especially our CDC Atlanta team, who are joining us late in the evening. And of course, thank you all the attendees for your participation, which demonstrates our collective commitment in tackling these complex health issues. Please continue with these important collaboration, and I wish you all a successful day. I will turn it back over to the moderator and facilitator. Over.
Ken for the remarks. Okay, thank you very much, Mr. Ken, for the remarks. Ladies and gentlemen, it is my pleasure to introduce our keynote speaker for today, Dr. Retno Wahyuningsih. Dr. Retno Wahyuningsih is the Senior Dean in University of Kristen Indonesia and University of Indonesia Faculty of Medicine for Mycology and Parasitology. She is also specialist in clinical parasitology. She has extensive experience as a speaker and has been invited to speak at various seminars, both domestically and internationally. She has been studying medical science for over 30 years, has over 28 awards, and recently was one of members of the WHO Advisor Group on the Fungal Priority Pathogen List. Dr. Retno Wahyuningsih, the time is yours.
Thank you very much, moderator. First, before I start to present my presentation, I would like to thank Dr. Dharma, the head of the BBLK, Dr. Dharmawali Handoko. Terima kasih, Dok, sudah mengundang saya, dan terima kasih kepada semua tim dari Kemkes yang telah menangani webinar ini dengan baik. Then I would like to thank Dr. Kenchen from Jakarta CDC office, and for Dr. Alex Jordan from CDC Atlanta. Thank you, Alex, for inviting me for this meeting. And I want to start now with my presentation. Let me share my screen. Okay. Thank you, everybody, for joining this meeting. Okay. Can you see my presentation?
Yes.
Okay. I want to display it, but just a minute. It takes time. Oh, okay. Now, so I work with fungal diseases for more than 30 years. And all this time, I'm seeing that we are having many patients with underlying condition that accommodates fungal diseases. So let me share my work during this time, and let's start with the magnitude of the problem in Indonesia. We know that Indonesia is a big country, very big country, with more than 17,000 islands, and it has also the biggest population in Southeast Asia. It consists of 17,000 islands located in the tropical island, warm and humid, and this climate accommodates the flow of the fungus. The condition of Indonesia with so many islands separated by the sea, in one hand, it is, of course, we have advantages because then the spread of the infectious disease is not as easy as the continents, continents like India or Australia. But disadvantages is that there is so many gaps between islands. In this case, especially about the mycology laboratory. Now let's start with the result of our work in the WHO. On 2022, WHO released a fungal priority pathogen list. And we can see here that so many fungus that is included in the list. But how is about Indonesia? We can see here that cryptococcosis, we have cryptococcosis, but not that as much as in the sub-Saharan Africa. And we have invasive candidiasis with so many causes, so many species, and aspergillosis, histoplasmosis, mucormycosis. These three are, I want to make a, what is it? Histoplasma and aspergillosis is the focus of my presentation today. We have three, Saccharomyces marneae and also Pneumocystis jirovecii. And from the result of risk test 2023, I saw that we have so many patients with diabetes, TB, cirrhosis, and we have see also the intensive antibiotic usage. All of these conditions are the underlying factors for fungal diseases. This is our work in UI. We published about the fungal burden of serious fungal burden in Indonesia. You can see here how is the annual rate, the percentage, the prevalence, etc. But I think this is underestimated because the data is limited. The data used in this work is only comes from Jakarta, from Java especially, and not from other part of Indonesia. That's what we have to discuss. What happens with my computer? So you can see here so many serious fungal diseases. That I'm sorry, my computer seems a little bit disturbed. And here we can see histoplasmosis, cryptococcus, histoplasma, Saccharomyces, invasive aspergillosis, mucormycosis, chronic pulmonary aspergillosis, candidemia, candida peritonitis, what is important. Here we have the Tinea capitis as one of the superficial infection, but we don't talk about many other superficial infection like dermatophyte because the data is limited and it's not a serious fungal disease. Even though nowadays we identify in other countries Tinea Indonesia, which is resistant against penicillin. Now let's see here cryptococcosis. We start the work of cryptococcosis in 2000, around 2000, when the HIV is booming, especially HIV get HIV infection because they are using the intravenous therapies. And we can see here the population is mostly HIV infection. Although I also identify some cases based on with underlying disease of hematology malignancy.
Coffee's not
and
ready.
most of them are suffering from meningitis. And some of them is skin dissemination. That's why we have here the HIV infection, the skin lesion suffering from cryptococcosis. Then we continue with candidemia. Candidemia is especially identified in Jakarta. So we have one or two from other cities, but mostly it's come from Jakarta. We see here that the most common cause is Candida albicans and then Candida tropicalis. When I start my work with candidemia in 1998, I start recognizing that Candida albicans is the most common parasitic agent. But nowadays, later on in 10 years, I saw that it shifted into Candida tropicalis. I don't know, maybe because we use so many fluconazole to treat Candida albicans, and Candida tropicalis is less susceptible to fluconazole. But then nowadays, after we are busy taking a funding, and funding, we know that there is an intrinsic of Candida parapsilosis that we know is less susceptible to mitochondria. So we can see here that the population is also adults and also pediatric. And I have to tell you here that some of them are missing symptoms, which is not used for diagnosis of Candida. Mostly, we have to isolate the fungus from the blood and relate it with the clinical signs and symptoms. Now I move to mucormycosis. Mucormycosis is considered rare at the moment, but we saw in India during the COVID-19 pandemic, the black fungus is quite auspicious. And we have here started to have that mucormycosis in the beginning of 2000. At that time, my senior in the hematology division sent us the patient, and we identified 4 cases of mucormycosis. And also, we all have a patient with abdominal wall mucormycosis because she did the surgery for the liver. And in later on, in 2010, I was identified mucormycosis also in the kidney mucormycosis, and some publication concerning the mucormycosis in the COVID-19 and also in the meningit. But during COVID pandemic, we saw that some patients, not only in Jakarta, because I had consultation from other cities, where some patients suffering from mucormycosis. And actually, this is not that difficult to identify if we know what kind of clinical material for the diagnosis. And this is some of my work in Department of Parasitology KUI during 2018 from one hospital from RSCM only. We have 8 patients with sinusitis because this disease is sinopulmonary disease and can be disseminated. And the most common is sinorhinoorbital cerebral myomatosis that we find in our laboratory. And most common risk factors is diabetes. Is only one type, leukemia. And our work using molecular-based method, we find out that mostly the cause of mucormycosis in Jakarta is Rhizopus. Rhizopus aereus or Rhizopus oryzae. And later on in 2019, 4 patients with sinusitis and rhinocerebral mucormycosis. In this work, show us that mucormycosis is real. But the problem is the diagnosis is not that easy, not because this is difficult to diagnose, but the awareness and also the laboratory is not available for the mycology diagnosis. And how about the pneumocystis irritati? This one is known as the co-infection in HIV infected patient. And we find my student at that time working using the monoclonal antibody, she can identify 14.6% of PCT patients. That's what interesting is that at this time, the most common pneumocystis irritati is not in the patient with HIV. That's mostly identify the disease in the patient suffering with ICU. So it must be considered that patient in ICU suffering from lung problems, tested also for this fungus. Then how about pararomyces? Pararomycosis in Jakarta, we published, is caused by 2 species. First is Thalaromyces arthrosis, and the second is Thalaromyces magnifi. And this is also isolated from the patient with HIV and also non-HIV patient. While skin lesion, we find it in some patients, and lung infection also reported from Yogyakarta, and skin lesion also reported from North Sumatra. And we saw here that the prevalence is so low. But my concept is that we have here Rhizornis sumatrensis. Rhizornis sumatrensis is jamur, and known as the reservoir in nature, known as the reservoir of Saccharomyces cerevisiae, and it is endemic in Sumatra. But the report is so scarce. So what we should do is this. I think we have to explore more about this Saccharomyces cerevisiae, especially in Sumatra, where the reservoir Rhizornis sumatrensis is endemic. Then I continue with aspergillosis. In Indonesia, we find aspergillosis is an invasive aspergillosis, acute form, usually in patient admitted to the ICU, and the chronic form, the chronic pulmonary aspergillosis, that is actually very interesting. So, how about the work on this invasive pulmonary aspergillosis? My student at that time working on the 6 ICU hospitals in Jakarta, and we find the prevalence is around 7.7%. But the diagnosis is only probable because we couldn't do biopsy for this patient. The condition of the patient doesn't allow us to do the biopsy. So the diagnosis was based on the clinical, radiology, risk factors, and also galactomannan test, and it is then compiled to reflect the diagnosis of IPA item in the laboratory, the ICU. And what's surprising is, as long as we know that Aspergillus nigricans is known as the main cause of this aspergillosis, but we found that Aspergillus flavus is the main cause of the invasive aspergillosis in Jakarta. I think this result is also in line with my previous work on the keratomycosis, which is also mostly caused by Aspergillus flavus, and the work of my teacher who worked on the environmental sample, and she found out that Aspergillus flavus is the most common Aspergillus found in the environment. So I think we have to work further because I couldn't find another work working on this invasive aspergillosis in Indonesia. So I think we have to explore more of this disease in many ICU in Indonesia. And maybe one clue is that this sometimes a sign of pulmonary diseases that we have to consider if patients suffering from sinusitis in ICU, we have to consider of doing diagnosis for invasive pulmonary aspergillosis. And now I go to the pulmonary tuberculosis and aspergillosis. Usually in this PTB, we find the chronic form, which has similar symptoms with PTB. That's why it is sometimes misdiagnosis that chronic pulmonary aspergillosis and chronic pulmonary and TB is the same chronic diseases, and it has both similar signs and symptoms. So sometimes it was misdiagnosis, and let's see what is the problem here. We know that Indonesia's second largest TB cases has second largest TB cases in the world, and incidence in 2021 is 354 per 100,000 population. And we find also TB in HIV, and we find also drug-resistant TB stand per 100,000 population. And mortality is high, 52 per 100,000, and in HIV is 2 per 100,000. So it is, I think we have to pay more attention to this condition. Let's see here. Some work was done about this CPA in Indonesia. First is my student, Siti Aminun, and she find out that around 6% of them are suffering. You can see the result here. But then we also work in Bandung area, and we saw here the percentage is higher, is 26.9%. And also I work with our team in Medan, North Sumatra, and we found out 52%. It's high. And in Manado, Dr. Wangko working on the TB patient, and he find it's sorry, this is slide. So we know here that even though the data is limited, we find out that TB and chronic pulmonary aspergillosis has the close relation. How is the population? Setiap minggu using confirmed and unconfirmed. Daily confirmed and unconfirmed TB. So also at Medan using MDR TB and Wangko using the TB. And how is the method? The method is the aspergillus culture, radiology, and clinical for setiap minggu, while the others using the antibody detection. Because antibody detection here considered as the cornerstone of the diagnosis of chronic pulmonary aspergillosis. And another surprising result is from the work of Daly and Siroso that histoplasma is also found in this population. Let's see next slide. So now we continue with histoplasmosis. I'm sorry, I back to my previous slide. That the work of this CPH is only limited and at Jakarta, Medan, and Bandung. We are lucky, three cities. That's also from Manado. But I think we have to look for another possibility of CPH in another places of Indonesia. And then I move to histoplasmosis. The first case of histoplasma is disseminated histoplasmosis was identified in a 7-year-old boy from Lumajang, East Java. It was identified by Dr. Muller in 1932 and published in the list in the Netherlands type at that time. And then since then, we have many cases reported for disseminated infection. Often, the disseminated infection was misdiagnosed as TB. So we can see here that why is only disseminated form? Because histoplasmosis has a broad spectrum of clinical sign and symptoms, broad clinical spectrum, which sometimes mimicking other diseases. As I mentioned here, TB is one of the disease that sometimes misdiagnosed with histoplasmosis. But I also find the patient with diagnosis as the hematology malignancy, who is diagnosed as hematology malignancy and not responding to chemotherapy, then later on it was sent to our laboratory and we can diagnose it as histoplasmosis, disseminated histoplasmosis. And we also find out the patient with liver transplantation, when she was suffering from respiratory problems, the doctor started to take care of as the other lung diseases, including aspergillosis, but then after discussion, we consider it as probable histoplasmosis treated by amphotericin B, and she became healthy, showing progress a week after administration of amphotericin B. Let's see here cases of disseminated histoplasmosis in Indonesia since 1932. Most of the cases were diagnosed in Java, in Bogor, Sukabumi, Bandung, West Java, in Brebes, Malang, and Yogyakarta, itu Central Java, and Surabaya, Gresik, and Lumajang, itu East Java. And I just had a discussion with Professor Putri Tawati from Bali, and she identifies some cases of disseminated histoplasmosis. And from Celebes Manado, Professor Puga, using the touch biopsy method, we can identify patient of disseminated skin histoplasmosis with touch biopsy method. And I found a note paper from Dowie from Australia, a patient who is an army located in Kalimantan. She Kalimantan or Borneo, and he didn't mention which part of Borneo. And this patient also suffering from histoplasmosis. So from this, we can find we can summarize that many histoplasmosis cases is distributed in many parts of Indonesia. Why Java? We have so many patients because microbiology laboratory is available. That's the problem. But let's see another clue that makes me consider Indonesia not only endemic but also hyperendemic of histoplasmosis. Histoplasma skin test. The most recent work on the histoplasma skin test is in 2019-2020. It is carried out in 6 cities: Jakarta, Bandung, Sukabumi, Semarang, Surabaya, Malang, and Manado. And the subject is chronic pulmonary disorders such as post-TB or chronic TB or COPD. And we work on 290 patients, and we find that 5 positive. Maybe if we focus on looking TB, the result will be higher. Let's see another result of my teacher about skin histoplasmosis test. It was done in 1950 and 1960. Indonesia, Jakarta, Professor Luciani find out 12.5% in adult and 2.7% in children positive for histoplasma skin test. Surabaya 32%, and the highest in the Kebisan Valley, 63.6%, so high, and Medan 13.6%. And we see here that the population is so distributed, not so diverse, not only the TB patient, but students, school children, nurses, and even the school children influencers. So we see here that histoplasma is exists in many parts of Indonesia. This is the result of our work, collaboration with Inarespon Indonesia, a study conducted in 7 TB referral hospitals in Indonesia. We find many patients having the antibody against histoplasma. So this is only 7 referral hospitals. Only Makassar will have patients. But I think if we broaden this work, we can find more of the patients also consisting of antibody. Another work is Bandung area. We work on confirmed TB patient and unconfirmed TB patient, and we saw that there is patient who is having the antibody against aspergillus fumigatus and histamine. So another work from North Sumatra in MDR patient, 1/3 of the patient is positive for histoplasma IgG. And there is some patients have a mixed antibody against histoplasma and aspergillus. So based on this result, we know that CPH and CPA, chronic pulmonary histoplasmosis and chronic pulmonary aspergillosis, is exists among the patients with TB. We have to consider this. And how about antifungal availability? We have this the azole derivative and echinocandin. We have amphotericin B. The problem is sometimes if we need amphotericin B, it's not available and it is difficult to find. But actually, amphotericin B is the life-saving drugs that must be available when the patient needs it. And now I jump to the WHO FPPR Indonesia context. I learned a slide from Satin. Satin is a chair of this FPPR, and we can see here some work that he proposed to be done to implement of FPPR in many countries. I start with this one. The first one is surveillance. Most data on mycosis, which I present now, comes from JAP, which has better laboratory access. A survey is needed to identify and determine the burden of disease in so many areas, in the large area of Indonesia. But to conduct good surveillance, access to mycology laboratory is needed, which is not yet available in these places. So with good laboratory, we can identify mycosis, mycotic disease, antifungal susceptibility test, so we can prevent the emergence of fungal antimicrobial resistance. The result of the survey done by Asia Fungal Working Group, including Indonesia, we find out Indonesia has so limited laboratory. So the availability of laboratory is essential to conduct the surveillance. And what I always said to my colleague that we need laboratory, not that very advanced laboratory mycology, but to develop the conventional diagnostic in many laboratories. If this conventional method available in many laboratories, I think 75% of the patient can be treated, can be saved. And if we have this method, if we can provide this method to have the patient, we can provide the right antifungal treatment, which also prevents the emergence of the fungal antimicrobial resistance. Conventional method use microscopic examination and culture. And I think in most of the laboratories, microscopes are available. And what we need is only to train human resources. So compared to the bacteria laboratory, infection laboratory of fungal diseases is limited. Researcher and technician also limited. Research funding limited. So we have a gap of knowledge. The gap of knowledge is huge. How about awareness of the clinician? How is the diagnosis by the laboratory? And we don't know the magnitude of the problem. The data comes mostly from Japan. And laboratory work, I propose conventional method to be conducted, to be provided in here. And how about public health intervention? Public health intervention is not merely to prevent and control infection and the emergence of diabaikan, but linked to the existing program. For example, TB management program that can simultaneously identify CPH and CPH. CPH is endemic disease. Endemic area mapping is needed. We need also working on other endemic mycosis, such as mycosis and sporomycosis, which the data is quite limited. And maybe others endemic mycosis we don't know yet. And how would R&D innovation? Develop research on fungal diseases and more funding. This means also we have to have more researchers working on fungal diseases. And international collaboration to the research, these researchers known to have extensive knowledge of fungal diseases. And they win fungal disease data center, so we know the exact magnitude of the problem. As a conclusion, Indonesia is a tropical country that is conducive to the growth of fungi. So the source of infection is available everywhere. Data on mycosis is scarce. It is related with the mycology lab. A need for better surveillance, as proposed by the WHO, needs access to laboratory, mycology laboratory. The specific problem lies in the availability of the human resources. And if we have this, even the conventional method laboratory, it will. And we have also considered that fungal disease is high because we have so many underlying that can promote fungal diseases. And also it is important to identify mycotic diseases in species populations such as this. And I think we have also to understand the interaction of antifungal drugs with other drugs, because we know that Indonesia is not endemic only for fungal diseases, but also for malaria. We have patients with HIV, which their drugs has interaction with antifungal. And for the future direction, I think provide more data to make a clear and visible decision in microcystis and frequent of FEMF. Adequate infrastructure needs to provide treatment. In addition, more research funds are required to study fungal diseases. Before I'm closing my talk, I would like to say thank you to all of my colleagues, my students, my collaborators. I will start from the tip of island from Sumatra. It is from the Universitas Sumatera Utara, Universitas Indonesia, Fakultas Medicine, Universitas Kristen Indonesia, Universitas Katolik Atma Jaya in Jakarta, Universitas Pajajaran in Bandung, Universitas Diponegoro in Semarang, Universitas Brawijaya in Malang, East Java, Universitas Udayana in Bali, Denpasar, Bali, Universitas Samratulangi in Manado, Los Angeles, and then also my colleagues from Indonesia, Jakarta, and my colleague from Darmais Cancer Hospital, where I start with the work on the fungal infection in HIV, and my colleague from Manchester University, Professor David Denny, and Professor Ferry Hafen from Western Institute of Fungal Diversity in the class, the Professor Conchita Torriolo, who provides the histoplasma skin test for our work, and also the funder for all this work from Indonesia Science Fund and Indonesia Endowment Fund, LPDP, and also from the fund. With this, I thank you for all of you for listening to my presentation. Back to moderator. Thank you.
Okay, thank you very much, Mrs. Retno Wahyuningsih, for the best presentation. Dear all participants, mengingatkan kembali bahwa pengisian pretest akan segera ditutup. Bagi para peserta yang belum menyelesaikan pretest, diharap segera mengisi link pretestnya menggunakan password Fungi, FUNGI. Kemudian untuk para peserta yang akan mendapatkan free sertifikat adalah para peserta yang telah mengisi pretest maupun posttest dengan nilai posttest adalah di atas nilai 70. Jadi dimohon untuk dapat mengikuti webinar ini sampai selesai. Baik, terima kasih. Pertanyaan session question and answer kita akan di akhir presentasi, jadi kita lanjut dulu ke acara selanjutnya. Bisa ditampung dulu atau bisa ditulis di kolom chat box. Terima kasih. Now we will move on the next presentation by a team from the US CDC regarding global fungal infection. Please, Mr. Alexander Jordan to lead. I'm so sorry. Okay, do you hear my voice? Okay. Please, Mr. Alexander Jordan to lead this session with your team. It is about 40 minutes. To Mr. Alex and the team, time is yours. Mr. Alex?
Thank you. Can you hear me okay? And can you see the slides okay?
Yeah.
Okay.
Perfect.
Thank you.
Yes, and thank you very much, everyone. I apologize. I'm going to leave my camera off for now. My internet has been a little slow, but I will turn it on later during the discussion. But yes, thank you so much for having us on this webinar. My name is Alex Jordan, and I'm the lead of the global unit at the CDC Mycotic Diseases branch. On behalf of all of us from CDC Atlanta, just want to say many thanks to the CDC Indonesia country office for coordinating this webinar and for inviting us. Thanks to Dr. Retno for her lovely presentation, and many thanks to His Excellency Dr. Handoko and the National Health Biology Lab and everyone else who has helped to make this webinar happen. And thanks to all of you in the audience for joining. We're very excited to be joining you virtually. Just to quickly mention, we are part of the CDC. We're based in Atlanta at the headquarters, but we work all over the world, and we also work very closely with other divisions at the CDC headquarters and with CDC country offices. So Dr. Retna gave a very wonderful overview, I think, of some of the priority pathogens, fungal pathogens in Indonesia. And so we're just going to be presenting briefly on some of the fungal disease work that our branch does globally, and we'll just be highlighting some global fungal disease priorities from our perspective at CDC from our global work. And then I'll be handing over to some of our other experts to discuss some of the specific fungal pathogens in more detail. So just to quickly mention, our branch goal or mission is really just to strengthen global health security through improving and building epidemiological, clinical, and laboratory capacity to address fungal diseases, which cause large burdens of sickness and death globally. Here I have just laid out some of the key categories of fungal diseases that we work on globally. I won't go into detail on these here, as we'll have other experts speaking to some of these in more detail later. But just to echo what Dr. Retna said about the WHO fungal priority pathogen list, most of the fungal pathogens which we target in our global work are included in this list. And this document has really helped to drive increased interest in addressing many of these diseases on the part of national governments and public health authorities globally. Just to quickly show a very maybe hard to see map of where we are currently active, but we're currently actively supporting countries and partners in more than 30 countries globally. Many of these are areas which are somewhat resource limited, and many of the countries we work with are really building fungal disease lab and surveillance capacity for the first time. And in terms of the types of support we offer, this differs depending on the country and the pathogen, but broadly speaking, we aim to provide technical support and expertise to countries and public health organizations to improve global awareness, and to increase the availability of national and regional fungal surveillance data, and to increase implementation of effective public health interventions which are targeting fungal diseases. So just to say, we're always eager to help. And as you can see on the map, we have not had a lot of activity in Indonesia to date. So we're very excited to be having this webinar today. And, if there's anything that would be helpful for us to discuss in more detail following the webinar, we'd be more than happy to do that. So I'll just quickly go over some of the priority HIV-associated fungal diseases that we support countries on. Dr. Retna already covered these in some detail, so I'll go through these somewhat quickly, but as mentioned, we're always available to share additional technical materials and have additional discussions following the webinar. As we saw in Dr. Retna's presentation, the fungal priority pathogens list includes 5 pathogens which are quite common causes of illness and death in people living with HIV. These include the pathogens which cause cryptococcal disease and cryptococcal meningitis, histoplasmosis, pneumocystis, pneumonia, and tularemycosis. And all of these are very serious diseases with high associated morbidity and mortality, especially if appropriate lab detection and treatment are not available. Cryptococcal meningitis, for example, is estimated to cause around 1/5 of all HIV-related deaths globally, and models suggest that there are probably tens of thousands of cases in the Indonesian region annually. Histoplasmosis is also a major cause of death in HIV patients, in areas where the histoplasma fungus is endemic. It often causes co-infection with TB and can also be easily mistaken for TB if appropriate diagnostics are not in place. Pneumocystis pneumonia is possibly the most common fungal opportunistic infection, or the most serious common fungal opportunistic infection in patients with HIV, and diagnosis of pneumocystis pneumonia, definitive diagnosis, is currently very difficult. And then lastly, talaromycosis is an important cause of HIV-associated sickness and death, especially in parts of Asia and especially in Southeast Asia. And in some of those regions, the incidence of talaromycosis is actually likely higher than that of cryptococcal disease and histoplasmosis. And I just also want to point out that all of these diseases occur most often in patients with advanced HIV disease, which is most accurately defined in adolescents and adults as having a CD4 count less than 200. And so CD4 testing access is also critical in order to effectively detect these diseases in the HIV population. And as Dr. Retna mentioned, all of these pathogens have been detected and reported in Indonesia. Cryptococcal disease, just to go through this quickly, cryptococcal disease occurs globally. If an area has patients with advanced HIV disease, then that area is also going to have cryptococcal disease and cryptococcal meningitis. Cryptococcal meningitis especially is a priority, as it causes very high mortality if not detected and treated early. Fortunately, there are cheap and accurate rapid diagnostic tests that can detect cryptococcal infection early in patient blood specimens, and this can be detected before disease progresses to cryptococcal meningitis. These tests detect the cryptococcal antigen, which is typically abbreviated as CRAG, and routine screening of patients with advanced HIV for CRAG, followed by preemptive fluconazole treatment, has been shown to be a cost-effective and life-saving intervention that can reduce both the incidence of cryptococcal meningitis while also improving detection of cryptococcal meningitis, allowing for earlier treatment that can save lives. The WHO strongly recommends the implementation of CRAG screening as part of a package of care for advanced HIV disease, as well as for routine detection of cryptococcal disease in hospitalized patients with HIV. And since the release of these many guidelines over the last few years from WHO, we have seen great improvements in many countries in detecting cryptococcal disease. And we have also seen some improvements in certain areas of the world in terms of access to the antifungals needed for induction therapy, namely amphotericin B, flucytosine, and fluconazole. But there are still huge gaps in terms of access to those antifungals, which needs to be addressed, as Dr. Retna mentioned. Histoplasmosis, as I mentioned, is differentially distributed in the environment, and the prevalence of histoplasmosis is going to be much higher in some regions of the world than others. But in recent years, we are seeing evidence that histoplasmosis is likely much more widespread than previously thought. And we really need to see more data from more parts of the world to better understand the actual distribution of histoplasma. But I think it's clear from Dr. Retna's presentation and the work that she has been doing that histoplasmosis does appear to be endemic in the environment in Indonesia, or at least in parts of Indonesia. Fortunately, similar to cryptococcal disease, there are recently developed rapid antigen tests, which test for the histoplasma antigen in urine specimens. And these are commercially available and have allowed for greatly improved detection of HIV-associated histoplasmosis in recent years. The WHO, basically due to evidence that the introduction of these histoplasma antigen tests as part of routine testing for patients with advanced HIV has been shown to reduce HIV mortality, and has also been estimated to be a cost-effective intervention in areas with high prevalence of histoplasmosis. So because of this, the WHO does now recommend routine histoplasma antigen testing as the preferred diagnostic in symptomatic patients with advanced HIV disease. Again, access to the treatment needed for histoplasmosis especially that needed for treatment of severe histoplasmosis, is still too limited. It has improved in some countries in recent years, but the drugs needed, namely liposomal amphotericin B and itraconazole, are still far too expensive in many parts of the world. And that's something that our branch, continues to work on in terms of advocacy. We really want to see these antifungal prices go down in the near future. Talaromycosis, previously known as penicilliosis, also a very important fungal disease endemic to parts of Asia. I think most experts consider it to be endemic in Indonesia. Again, I think Dr. Retna's work shows that it is likely endemic to some extent in Indonesia. A key challenge with talaromycosis is that the routine diagnostic methods lack sensitivity, and so cases are often diagnosed too late. The good news is that a recently developed ELISA and lateral flow assay test, which can detect Talaromyces antigen in blood and urine, appear to be highly accurate, and these, if commercialized, would allow for rapid diagnosis in high-risk patients, such as those with advanced HIV. So there's a lot of hope that these tests could sort of be a game changer in terms of routine detection of talaromycosis in HIV programs. And there's also hope that these could even be deployed as screening tests for anyone with advanced HIV disease in areas endemic for talaromycosis. And there's a number of clinical trials ongoing, primarily in China and Southeast Asia, which are looking at the feasibility and impact of using these tests, these antigen lateral flow assays, in a screening context. As mentioned, pneumocystis pneumonia is a very common fungal disease, probably one of the more common in patients with HIV, but it's also one of the more difficult to address from a public health perspective. Despite the widespread availability of Bactrim or cotrimoxazole for preventive therapy in people with HIV, it still appears to be a pretty common cause of hospitalization in patients with advanced HIV, and outcomes of those patients are often poor, especially in resource-limited settings. Part of the challenge is that a confirmatory diagnosis of pneumocystis pneumonia is challenging in many regions, as it relies on bronchoscopy or induced sputum, and requires PCR tests typically to confirm. And these diagnostic methods are not easily available in many high-burden HIV countries. The symptoms of pneumocystis pneumonia are also very non-specific, and so that means that much of the diagnosis and treatment of pneumocystis pneumonia currently is being done empirically. One issue with pneumocystis pneumonia is also that most of the key research on prevention and treatment was done decades ago. It's very hard to find recent research looking at preventive or treatment regimens and their efficacy in recent years. And so basically, I've just flagged here that, for when it comes to pneumocystis pneumonia, what we really need are more data, and we really need advances from the research community, both on the diagnostic side and on the treatment and preventive side, before we feel that we could most effectively address this disease as part of routine public health programming. And I've just put a link to the recently published Advanced HIV Disease Research Landscape here, which goes into more detail on this. So I'll stop there. I've linked here to some key resources for fungal opportunistic infections, and I'm sure we'll be sharing these slides after the webinar. So thank you everyone for listening. I'll now hand it off to Dr. Sean Lockhart to talk a bit more about antimicrobial resistant fungal diseases. Thank you.
Good morning, everyone. I'm Sean Lockhart from the CDC. I am the Mycotic Diseases Branch Senior Advisor for Global Capacity Building and AMR. And I've been studying fungi for over 30 years now. So if you look at the fungal priority pathogen list, you can see that there are a number of Candida species on this list, all the way from the critical group to the medium group. And many, if not most of these, have the ability to become antifungal resistance, especially Candida glabrata, Candida albicans, and as I'll talk about later, Candida parapsilosis, and Candida krusei is intrinsically resistant to fluconazole. So we have some organisms that are high on the list. They're very prevalent. Probably Candida is the most common fungal infection encountered in any hospital anywhere in the world. And these are bugs that can be difficult to treat because of antifungal resistance. Next slide, Alex. So, unfortunately for us, resistance is on the rise, and there's a number of reasons for that. We'll start at the bottom with Candida auris. This is a bug that tends to be resistant. Over 90% of isolates are resistant to at least one antifungal, and this bug is circling the world. But we're seeing a rise in antifungal resistance amongst the more common Candida species. We're seeing it in Candida parapsilosis with increasing rates of fluconazole resistance around the world. We're seeing it in Candida tropicalis with this increasing rates of fluconazole resistance in both Southeast Asia and in Latin America, in Southern America, South America. And we're not seeing an increase in resistance in Candida glabrata, but we're seeing an increase in the incidence of Candida glabrata. So as the proportion of Candida infections that are Candida albicans go down, the proportion that are glabrata, parapsilosis, and tropicalis, all of which can be drug resistant, is going up. Next slide. So Candida parapsilosis is a bug we used to worry about a long time ago. It was the most common Candida species to cause outbreaks in the hospitals. And there's a reason for that. Candida parapsilosis is a colonizer of the skin. And because of that, it's very easy to transfer it from patient to patient. It also has the ability both to perform, to grow as a biofilm, and it remains viable on surfaces for weeks. So it can sit in the hospital as a contaminating bug for weeks at a time without dying. And that makes it a real problem. It was the predominant species causing outbreaks and still is in neonatal intensive care units. We thought that it had mostly gone away after we started incorporating infection control for Staph aureus and other bacteria. We saw Candida infections of the caused by skin colonization go down as well, but now we're seeing a rise once again. What's very concerning about Candida parapsilosis right now is that we're seeing resistance to fluconazole. And this is arising all over the world. We're seeing it in Africa. We're seeing it in Europe. We're seeing it in South America. We're seeing it in North America. And we've seen it very recently in parts of Asia. Now, it's not spreading. It is spontaneously developing resistance in each region and then spreads solely within that region. So when we look at whole genome sequencing of these isolates, we know that it'll spread in a city and sometimes in several cities, but it doesn't seem to be spreading from country to country. Even more interesting, every one of these resistant clones that arise has the exact same mechanism of resistance. So it has the ability to flip this switch and become resistant. Next slide, please. The bug we used to worry about the most was Candida glabrata, and that was because it had about 10% on average resistance to azoles, and the very rare 1% of isolates that were resistant to both azoles and echinocandins. Next. Until we got to Candida auris. And all of a sudden we have a bug. It's not intrinsically resistance. This is all acquired resistance, but 95% of global isolates are resistant to at least one antifungal, and 25% of isolates are multi-drug resistant. We've even identified in several different countries pan-resistant isolates. So isolates that are resistant to all three classes of drugs that are given for systemic fungal infections. Next slide. This is what we know about Candida auris right now. Now, look at this map and keep in mind that back in 2015, 9 years ago, we had only identified it in 4 countries. Now, we don't believe that these are the only countries where we find Candida auris. What we believe is that the countries that are still in gray on these maps either haven't looked or don't have the ability to look right now. We believe that this is now a global bug, and it's one that has spread from country to country. 4 individual clones have moved across the entire world from country to country and established themselves in most countries in the world now. So this is very, very alarming. Next slide, please. Now, Candida auris, similar to Candida parapsilosis, rather than being a gut bug, is a skin bug. It's found on the skin of patients. And because of this, it can be transmitted from one patient to another. We find it in multiple sites on the hands and the groin, in the axilla, the ears, the nares. We even find it in between the fingers and toes. We recommend screening for Candida auris by looking at the nose, the axilla, the groin, or other body sites by screening it with a swab and then using that swab to inoculate culture and grow Candida auris. The alarming part about auris is that colonization persists for a very long time. We have some patients that have been colonized for years and years, and we don't have the ability at this time to decolonize a patient. We don't know. We can turn down the amount of auris on their skin, but we don't seem to be able right now to completely get rid of it, which means that when these patients go back into a hospital environment, they're again able to spread it from patient to patient. When a hospital becomes contaminated with auris, it's very, very difficult to eliminate. Next slide. Now, you may think getting it on the skin doesn't really seem to be a problem. There are no signs and symptoms. Well, that's one of the big problems, because you can have one patient come in and within a week, 10 patients are colonized because there's no way to see, there's no itchiness, no rash, no redness. Doesn't do much. But we now know that 5 to 10% of patients who become colonized go on to develop bloodstream infections, which of course can be deadly. And depending on where you are in the world, the mortality can be up to 40% within the first 30 days. And in some sites where drugs are much harder to come by, that can be even higher, up to 60% or more. Next slide. Now, the other problem with Candida auris is we don't find it in healthy patients. We find it in the sickest of the sick, in patients who already have an underlying problem that when you add Candida auris on top of that, just makes for an incredibly difficult hospital stay. We find it most often in persons with invasive devices, persons on ventilators, persons who have other multi-drug resistant organisms, carbapenems, Acinetobacter, Pseudomonas, things like that, and patients who are receiving antibiotics and antifungals. At this time, we don't identify it as a threat to the general public. We don't see it so far in otherwise healthy patients and patients who have an intact skin flora. But the thing that we know about Candida auris is we don't know enough about Candida auris, and it has slowly changed over time. Actually, it's actually quickly changed over time. And although we say we don't see it in the general public today, that doesn't mean that 1 or 2 or 5 years from now, it won't be circulating outside of the hospital setting. Next slide. As I said, it persists in the environment. So once it's in a hospital room, it's extremely hard to eradicate. You find it on the bed rails, the sink, the chairs, the floor. We've even detected it on the ceiling. It contaminates any of the equipment used in the room, and it requires very specific disinfection. The best disinfection is bleach, but it's tough to go into a room and spread bleach everywhere. It smells horrible. It can be caustic to the eyes and to the hands. But other common disinfections, such as quaternary ammonia compounds, don't work. What we do know that works is combinations. So a quaternary ammonia plus some other, plus an alcohol, plus a hydrogen peroxide or something. So combinations will also work besides just using a bleach. Next slide. The only way really to prevent the spread of Candida auris is to detect it early in patients. When you get one patient in the hospital who has Candida auris, the best thing you can do is to screen other patients who are sharing a room, who are sharing a bed. If you find more, screen patients who are sharing the ward and go outward in concentric circles from that first patient. The other way to control it once it's in your hospital is through strong infection control practices, through PPE, through contact precautions, and making sure you identify patients and treat them carefully using contact precautions. Next slide. So we go back to the basics. Good hand hygiene, transmission-based precautions. In other words, wearing gloves and gowns, but not wearing them from one room to the next, changing them as you leave the room. And then, of course, the hardest part, but the most important part, is cleaning the environment, disinfecting everything, not just the patient bed, but the patient equipment, the floors, the ceilings, the chairs, just really covering that room so that you know you're getting all of the RS out of there. Next slide. Don't wait till you have a case. If you already have infection control practices in your hospital and you are looking for other multi-drug resistant organisms, Acinetobacter, Pseudomonas, carbapenem resistant Enterobacteriaceae, go ahead and add Candida auris to your screening list. Find a protocol that allows you to screen. There are some cheap ways to do it. We can talk about it in the question and answer session, but think about adding this to your IPC strategies. Next slide. There's one more organism I want to tell you about before we go on to the next speaker, and that is Trichophyton indotineae. So when we think about trichophyton or ringworm, we usually think about small lesions the size of a coin. Maybe there'll be 2 or 3, but they tend to be small. We now have this new infection, this new dermatophyte that causes infections that cover the entire trunk, the entire groin, all the way up into the face. They're extremely pruritic, they're itchy, they're awful, and they're spread person to person. But the most important thing about these infections is they tend to be terbinafine resistant. We haven't had to worry about terbinafine resistant infections in the past. We give it to our patient, it generally tends to work. But now we're seeing this terbinafine resistant tinea infection that covers large parts of the body. and it's circulating the world now, spread outward from somewhere in Southeast Asia. Next slide. We think it's been modified due to the use of over-the-counter drugs. So in lots of places, you can buy a drug that has a number of things in it. It has 1 or 2 antibiotics, it has an antifungal, and then it has a steroid. And, you know, if you have a non-infectious skin lesion, putting a steroid on it can stop some of the symptoms, but putting a steroid on a fungal infection just amplifies it. And so we've seen these amplified infections, these huge, horrible infections that cover the entire body from the over-the-counter use of these creams that have very high potency steroids as well as antifungals in them. Next slide. So I think, is this me or Alex, are we starting?
Sorry, Sean. Yeah, I think we just wanted to mention the glass fungi real quick. So just a couple of slides on
I
that.
think those were that last slide was Allison's start, correct?
Yeah, I think if you can just cover them real quick, we're thinking
Okay,
just in
yeah.
terms of
So back
time.
up a little. Do we have, so you want to just start here?
Yeah, maybe here.
Okay. So right now we have very little global fungal surveillance. As you saw from Dr. Retno, there are very few organisms that have been recorded from Indonesia. We have a few cases from a few hospitals. It seems to be mostly in Jakarta. And that's the case around the entire world. We have single case reports from hospitals, things like that. There is no global fungal surveillance right now. And so it's very hard to track resistance. It's very hard to track emerging threats. It's very hard to track transmission. Next slide. But we now have a new program called GLASS AMR at the WHO. This program has been voted on by all UN countries, and they've all agreed. It started out with antibacterial surveillance, and about 50% of countries now across the world perform some sort of surveillance and contribute data to this large global database at the WHO called GLASS. Next slide. In 2024, for the first time, a fungus was added to GLASS. So we now have GLASS fungi, and we're starting with candidemia or candida bloodstream infections, but we hope to move into other fungi as we start to enroll countries in this surveillance. So this is the first time anywhere in the world that we will have global surveillance for a fungal infection. So we're really, really excited about this system. Next slide. So we're starting with bacteria, and who knows where we're going to go with fungus. We know a few countries have started this year already, and we're hoping that this spreads across the rest of the world. Next slide. Okay, thank you.
Yeah, thanks, Sean. So we'll hand it over to Dr. Dallas Smith to talk a bit about our fungal NTDs.
Good morning, everyone. Thanks so much for the opportunity to allow us to talk about fungus today. And I get to talk to you about neglected tropical diseases and just reminding all of us that we should not forget about fungi when we think about NTDs. Next slide, please. And so fungal diseases may be the most neglected of NTDs, and we all know that NTDs are neglected in general. And so the World Health Organization has a list of fungal NTDs, and many of these are implantation mycoses, which means the fungus is actually implanted into the skin after traumatic injury occurs. And so one of these fungal NTDs is called mycetoma, which was added in 2016. And then in 2017, another implantation mycosis called chromoblastomycosis was added. Interestingly, when chromoblastomycosis was added in 2017, they added this phrase afterwards, this and other deep mycoses, but didn't really define what that means. And so we've been thinking about, well, what does other deep mycoses mean? And so this could mean sporotrichosis, paracoccidiomycosis, and lobomycosis. But today, I'm just going to talk about two of the fungal entities, mycetoma and chromoblastomycosis. Next slide, please. And so mycetoma, chromoblastomycosis, and many others of these implantation mycoses share common features. They're most common in tropical and subtropical areas, although disease can occur anywhere. They affect poor communities that typically do not have access to healthcare and proper sanitation and water. They are usually more prevalent in rural areas. And this is likely due to occupational exposure. A lot of people who get these diseases are farmers or people working outside. They're also classified as skin NTDs, and maybe many on this call are familiar with some of the more well-known skin NTDs like leprosy or or uh, or some of these other skin NTDs. But these ones cause severe disability, severe lesions that can really impact patients' quality of life. As you can see from the pictures on the bottom here, you see on the left-hand side, you see a very substantial lesion of mycetoma that's invaded the bone and very difficult to treat. In the middle, you see chromoblastomycosis that has led to tissue fibrosis and makes it difficult for the patient to walk. And on the right-hand side, you see a pretty severe case of sporotrichosis. And so these are very, very substantial diseases that cause and are public health problems in many parts of the world. Next slide, please. And so these are global health problems. As I just mentioned, they cause devastating morbidity, including amputation, especially with mycetoma, or for example, with chromoblastomycosis, it can lead to skin cancer. They cause stigma in communities. Many times, patients with these diseases are ostracized from their communities. It leads to a loss of quality of life. And although rarely it can lead to death, it just causes many problems for these patients. And we often don't address them properly globally. Next slide, please. And so the burden estimates for mycetoma specifically are based on case reports. And so we don't have great surveillance globally. And so we don't know the true burden. We don't know the true incidence of these diseases really anywhere in the world, except maybe a few countries that have a national response to mycetoma. Next slide, please. However, I did want to pull some case studies that have been published in Indonesia. And so mycetoma can actually be caused by fungi or it can be caused by bacteria. And so if it's caused by fungi, we call it eumycetoma. If it's caused by bacteria, we call it actinomycetoma. But just in the last few years, there have been case reports that have been published about both eumycetoma and actinomycetoma being present in Indonesia. And so this disease, this devastating disease, is present in Indonesian communities, but we don't know the true burden. We don't know how common it is. We don't know how many times it leads to amputation. And I think a concerted public health effort can really start addressing this really horrible and awful disease. Next slide, please. And so kind of transitioning from mycetoma to chromoblastomycosis, we do see that certain parts of the world seem to have high reported incident rates of chromoblastomycosis. Some of the places that we see include parts of the Amazon region of Brazil, the northern part of Venezuela, Madagascar, and other places in Latin America. However, we don't know if this is due to actually having more disease or if it's just reported more often because of publications, because they have the ability to diagnose the disease. Next slide, please. But we do know that chromoblastomycosis is present in in Indonesia, especially in rural parts of Indonesia. And this is a really interesting initiative that is being done by different colleagues in Indonesia. And they're using teledermatology and partnering with community health workers to diagnose and treat chromoblastomycosis. And so this is a really cool initiative that is, one, identifying chromoblastomycosis as a public health problem in Indonesia, but also making sure that we equip community health workers and those working on the ground with the expertise to be able to treat this disease as well. Next slide, please. And so I want to talk a little bit about fungal NTD gaps that exist both globally and in Indonesia. Next slide, please. And so thinking from a global perspective, little progress has been made on the World Health Organization NTD roadmap, which includes mycetoma and includes chromoblastomycosis and indicators for these two fungal NTDs. And in the 2024 update, we saw that little progress was made. There's only 7 countries globally that reports mycetoma. And as you can see, there's none in Asia that actually report mycetoma to the World Health Organization. Only 1 country in the entire world reports chromoblastomycosis cases. And unfortunately, we have no disability adjusted life year estimates for any of the fungal NTDs. And we think these DALYs, or these disability adjusted life year estimates, can provide a true or more true burden of the disease rather than just incidence, rather than just prevalence, because we actually capture the impact that these devastating diseases have on patients' lives. Next slide, please. The World Health Organization recently conducted a survey among anybody willing to participate on implantation mycoses, including mycetoma, including chromoblastomycosis. And I just want to point you to the bottom of the screen first about the demographics of the respondents. So this is most respondents, so 52%, were actually from upper middle income and high income countries. But as you can see, when looking at the primary care level, when looking at the secondary care level of healthcare facilities, many of these diagnostic tests are not available. And so as you can imagine, in low-income countries and low-middle-income countries, this is even worse, and access to diagnostics is even worse. And so we really need to work as a global and local units to be able to improve diagnostic training and access. Next slide, please. And so this is the same survey that the World Health Organization did, but this time they focused on access to treatment. And just a little background, itraconazole is typically the first-line treatment for mycetoma, which is mycetoma caused by fungi, and chromoblastomycosis. And when given consistently over a period of 6 to 12 months, it can have pretty good efficacy, especially if started in early disease. However, as you can see from this survey, 56% of people were not able to use antifungals because they were either not available or not affordable. And when you look at the specific antifungals mentioned, you see that itraconazole, the third one on the list on the chart to the right, had lots of responses. So 17 of the individuals, which was about 50%, said they had no access or had problems accessing or just not available, which is, as I mentioned, the first-line treatment for these diseases. And so access to itraconazole, access to antifungals is a problem as we think about how we can diagnose and treat these fungal NTDs. Next slide, please. And so I just wanted to highlight this global antifungal access issue a bit more. And so this is a completely different study, but this study looked globally about access to itraconazole. And the researchers estimated that at least 78 million people have no access to itraconazole. And this doesn't even account for people who are unable to afford itraconazole in their country. And by talking with colleagues in Indonesia, we do see that there are access problems to itraconazole, especially in more rural areas. And so we need to partner together to be able to, one, increase diagnostic capacity, but also be able to increase access to itraconazole in order to properly care for these patients suffering from these devastating diseases. Next slide, please. And so I just want to end on a few different fungal NTD activities that CDC is helping to lead. And we would really love everyone on this call, if you're interested, to join in on these developments. So the first one that I want to talk about is that we have working groups for our fungal NTDs that anybody is welcome to join. Clinicians, public health, researchers, anybody that's interested in these diseases, we welcome them to join. And so we have a global mycetoma working group, a global chromoblastomycosis working group, and a One Health sporotrichosis working group. So if you are interested in joining, please send me an email, which is down in the right-hand corner. Next slide, please. The other thing we've been working on recently is a global mycetoma working group roadmap where we outline key activities that we think needs to happen in order to control mycetoma globally. And some of our immediate priorities are making sure we can conduct a global mycetoma surveillance project. We want to develop diagnostic and treatment guidelines, establish global case definitions, improve access to and training for certain diagnostics like ultrasound technology, which can distinguish mycetoma from other skin diseases. We also want to encourage countries to make mycetoma nationally notifiable so that we have better surveillance, both regionally and globally. Next slide, please. And so I just wanted to briefly mention that we are conducting a 2-year prospective surveillance project for mycetoma in partnership with the Drugs for Neglected Disease Initiative and the Global Mycetoma Working Group, which I mentioned before. And so CDC is overseeing data collection from at least 9 countries, but we are always open to welcoming more. And we currently do not have someone in Indonesia who's interested in participating in this study. We're utilizing a standardized case report form, and we are utilizing a central database. And we're looking at both actinomycetoma and eumycetoma. Surveillance has already started. It started earlier this year, but it will end of next year. And so there's always time to participate. Next slide, please. We also just recently will be publishing our global chromoblastomycosis strategy in the next week. I think it comes out. And so some of the things that we highlight that we need to contribute to in order to better understand chromoblastomycosis is what's the impact of climate change on chromoblastomycosis? How can we improve access to microscopes and training for direct mycological examination? We need standardized treatment guidelines. How can we better integrate chromoblastomycosis and other fungal NTDs into existing NTD infrastructure at global, national, and subnational levels? Next slide, please. One of the other things I want to mention is that, as Sean Lockhart mentioned in the previous presentation, that we are seeing the rise of antifungal resistance in multiple different fungi. And so we are concerned about resistance developing in some of these fungi that cause chromoblastomycosis, for example. And so what we've been doing is we're developing these measures or these values. They're called epidemiological cutoff values, so that we can monitor for resistance or at least mutations in fungi as we continue to just monitor for resistance globally. Next slide, please. And so the other thing we're doing, and I mentioned earlier, is that we want to go beyond just defining the prevalence or the incidence of these diseases, and we want to measure the quality of life. And so we are utilizing the Dermatology Life Quality Index tool to measure the true burden, or at least a better version of the true burden of chromoblastomycosis on patients. And so we are collecting data currently in Brazil and a few other countries, but we're always open to extending to other regions. Next slide, please. And my final slide that I had was that I just want to let you all know that we have developed trainings through the Open World Health Organization platform on fungal neglected tropical diseases, specifically for chromoblastomycosis and sporotrichosis. And so I'm happy to put those links in the chat in case people are interested in learning more specifically about these devastating diseases. Next slide, please. And that ends my presentation. Thank you all so much for letting me talk about fungal NTDs. And I think we are open for questions, but I'll turn it back to the moderator.
Presentation. The Honorable Ladies and Gentlemen, let us proceed for the discussion session. We have about 10 minutes. Please ask your question via chat box or raise hand. Okay, for the first participant, Mrs. Sri Kurnia. Mrs. Sri Kurnia, do you hear my voice? Bu Esther, bisa tolong dibantu? Atau Bu Tasya? Ya. Atau mungkin bisa via chatbox terlebih dahulu ya. Baik, ini sudah ada 3 pertanyaan. Yang pertama dari residen mikrobiologi klinik. What are the prospects of using multi-toph for identifying pathogenic fungi, considering that fungal identification can be quite challenging? Mr. Sean or Mr. Dallas, is there any explain more answer or information, or it is enough? And then second question, how we can manage mucormycosis when amphotericin B is not available? And then the third question, what are the prospects? Oh, it is the same from the first question. Okay,
Yeah.
Mr. Dallas or Mr. Sean?
Yeah, I'll go ahead and answer the first question. We are
Yeah.
very excited about the prospects of multi-toph and fungi. It's very expensive to start. It's very expensive to buy a multi-toph machine, but once you have it, then it's very, very cheap to run. And it works excellent for yeasts. The databases are very, very good. Most yeasts are identified to species, and it even goes down into some of the subspecies and rare species. It's not quite as good for molds yet. And I say yet because I think the reason it's not very good for molds is we just don't have the database built up enough yet. I think once we've got good enough databases, MALDI will become a gold standard, just like DNA sequencing. I think it will be an excellent, excellent tool. And if you've got MALDI in your hospital already, you can buy a database just specifically for fungi. Use the bacteriologist's machine. They don't get everything. The fungal people need to get some stuff every once in a while. So buy the database, put it in that bacteria machine, and share it between mycology and bacteriology. Over.
Okay, thank you, Mr. Dallas. And then next question is from Kesda Trenggalek by Mr. Iskandar. Sporotrichosis transmitted through animal bites is primarily caused by which species of fungus? How to treat and prevent this fungal disease? Please, Mr. Dallas, you can explain.
Yes, happy to answer this question. And so sporotrichosis is caused by sporotrich species. And historically, Sporotrichosis was normally transmitted by plants, by soil, and by a sapronatic route. But probably in the early 2000s, a new species emerged in South America, specifically in Brazil, called Sporotrix brasiliensis. And this new species is behaving as a zoonotic fungal disease, and cats are serving as the main vector. And so this new species is spreading rapidly, and it is causing and has caused an epidemic of sporotrichosis from cat to cat transmission, cat to human transmission as well. So it's a very big concern of ours, as a significant public health problem that could spread to other areas of the world. The other thing I want to mention is that currently in Malaysia and in Thailand, we are seeing many cases of zoonotic sporotrichosis caused by the older species, Sporotrix shankii. And so we have some concerns that in Southeast Asia, this species may be adapting or changing to become more of a zoonotic disease and may be able to spread easier from cats to cats and cats to humans. And so we think to be able to prevent this fungal disease, we really need a One Health approach. We need to make sure we're working with veterinarians. We need to make sure we're working with people who care for cats in order to address zoonotic sporotrichosis. We need to make sure we properly treat cats as well. If we treat the cat, that means once they're treated, the cat can't spread it further. And so we really need a One Health approach to addressing sporotrichosis.
Okay, it is clear. Thank you very much for the answer, Mr. Dallas. And then next question is Mrs. Sri Kurnia, Mr. Tri Wijatmiko, and Mr. Ahmad Saputra. Do you hear my voice? Oke, mungkin oh, Mr. Ahmad Saputra, Mr. Triwijatmiko. Oke, mungkin nanti pertanyaannya bisa disampaikan lewat chatbox untuk Ibu Kurnia, Mas Tri, dan Pak Rahmat. Baik, para peserta, saya mengingatkan kembali untuk pengisian link pretest akan segera ditutup pada pukul 10.30. Kemudian tidak lupa juga untuk nanti mengisi post-test. Batas pengisian waktunya sampai pukul 16 sore. Dan nilai yang akan mendapatkan sertifikat batas nilainya adalah lebih dari 70. Diharapkan para partisipan bisa mengikuti acara ini sampai selesai. Baik, para peserta, apakah ada pertanyaan tambahan untuk Dr. Retno Wahyuningsih? Bisa via kolom chat box atau please raise hand.
Ibu moderator, saya bisa memberikan sedikit tambahan.
Oke, baik Bu, silakan Bu Retno.
Baik, terima kasih. I want to comment on your presentation, Sean, about the Candida cruciae that you mentioned about Candida cruciae is primarily resistant to fluconazole. But in Indonesia, we find strain that is still susceptible to fluconazole. And we work with whole genome sequence. It was supported, and also with clinical result that the patient who is suffering from infection of this Candida cruciae while treated with fluconazole, the response is quite good. That's it. Thank you, Father. Kembali ke moderator.
Baik, terima kasih Mrs. Retno. Honorable ladies and gentlemen, we have come to the end session for this webinar. I would like to invite Dr. Herna, SPMK, to convey conclusion and close the event. Mrs. Herna, time is yours.
Ya, terima kasih Bu Moderator, Bu Janu ya yang sudah mengawal acara ini. Terima kasih sekali kepada Dr. Retno, kemudian juga kepada expert dari CDC untuk bisa berbagi sharing informasi terkait dengan penyakit yang disebabkan oleh jamur ya. Nah, sebagaimana kita ketahui kan memang mungkin penyakit jamur ini kurang populer ya di Indonesia, padahal sebenarnya banyak. Nah, ini mungkin pentingnya ke depan mungkin ada perkembangan terkait dengan jamur, apakah nanti terkait dengan surveillance-nya, karena saya rasa belum tersentuh sama sekali. Juga fasilitas pemeriksaannya mungkin tidak terlalu banyak juga ya. Mungkin yang biasa dilakukan adalah jamur-jamur yang biasa ada di Indonesia seperti jamur-jamur di kulit, di epidermidis atau subepidermidis. Jadi kalau kita ketahui bahwa ternyata penyakit jamur itu bisa banyak ya, ada yang invasif dan akhirnya nanti bisa menyebabkan kematian juga. Jadi saya rasa sangat bagus sekali ya mengikuti webinar ini karena webinar ini sangat bermanfaat sekali buat kita semua. Saya rasa semoga apa yang telah dipaparkan oleh para kolega ya, Dr. Retno dan juga para expert dari CDC supaya bisa menjadi membuka wawasan kita ya supaya ke depannya bagaimana strategi terutama Indonesia ya dalam terkait dengan penyakit yang disebabkan oleh jamur ini. Baiklah, saya rasa sudah sampai pada ujung acara ya. Saya ucapkan terima kasih kepada semua peserta. Saya mewakili dari Pak Koko, Pak Darmawali Handoko, karena beliau sedang ada acara di tempat lain. Jadi saya mewakili beliau dengan ini menutup acara ini. Terima kasih semua. Saya kembalikan kepada Bu Moderator. Terima kasih.
Thank you very much, Mrs. Herna, for the best closing. Okay, for documentation, it will be great if you take a picture of all participants of the webinar. Please open camera and give me the best smile. Okay.
We're asking everybody to open their camera.
Okay. First screen. Okay, next. Okay, next. 1, 2, 3. Okay, thank you. It is enough. Thank you for making time with us, and please allow me to convey our humble apology for any shortcomings in the arrangement of this event. All the speakers and participants who attend, thank you very much for your kind attention and cooperation. We hope this webinar can useful and increase our awareness of fungal infection in Indonesia. I look forward to see you again on the upcoming collaboration events. Have a great rest of your day. I am Janu signing off. See you next time. Keep peace and blessing. Wassalamualaikum warahmatullahi wabarakatuh. Untuk password post-test nanti akan diinfokan setelah selesai acara. Oke, baik. Terima
Thank you,
kasih.
everybody. I'm leaving now. Thank you, Alex. See you again.
Iya, silakan Bu Retno.
Ya, saya pamit ya.
Oh ya, terima kasih. Bye-bye, goodbye. Mr. Dallas, Mr. Sean.
Thank you.
Thank you, Mr. Alex. Thank you, Mrs.
Thank you.
Esther and Tasha.
Bye-bye.
Bye-bye.
Thanks.
Have a
Bye-bye.
good
Thanks,
day.
everyone.